Auzubillahi minash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. I am Professor Muhammad Badar Bashir, and in today's lecture, we will be discussing, inshallah, about the pathophysiology of the diabetes mellitus, its clinical features, and how to diagnose it, and what are the different tests which we need to perform when we diagnose a patient with diabetes mellitus. So, regarding the pathophysiology of type 1 diabetes mellitus, as we discussed in the last lecture, that it is a disease which is most probably related to autoimmune process. Due to certain environmental insult, body produces certain antibodies which acts against beta cells in islets of Langerhans, and insulinitis is the result. Due to the inflammation of the islets of Langerhans, ultimately insulin producing beta cells, they are destroyed, and ability of the body to produce insulin is lost. And that is the reason why in patients of type 1 diabetes there is loss of insulin, lack of insulin in the body, and ultimately person fails to maintain euglycemia in the body, and hyperglycemia is the result. Because insulin plays main role in homeostasis of the glucose in the body. It is related to glucose production by the liver, it is associated with glucose uptake by the liver, and it is also directly related to the blood glucose utilized by the peripheral tissues. Once insulin is not there, hyperglycemia results, and due to hyperglycemia different complications may occur. So at the mainstay of type 1 diabetes pathophysiology, autoimmunity is the play a main pivotal role, and antibodies against islet cells and antibodies against insulin are present in the body, which are ultimately which are responsible for the destruction of islets of Langerhans and failure of insulin production in the body. When we talk about the pathophysiology of the type 2 diabetes mellitus, that is far more complex as compared to the pathophysiology of type 1. Usually, initially, when about certain years back, we only know about insulin resistance and beta cell dysfunction. These were the two main culprits known, which were related to the development of type 2 diabetes mellitus. But nowadays, a third component is also very well known in the pathophysiology of type 2, and that is called as incretin impairment, that is the impaired incretin action. And talking about incretin effect a little bit in detail, that incretin effect is seen in the body when we compare the levels of insulin once the body is injected IV glucose, and the same amount of glucose when it is given orally. So as shown in this graph, when the patient is injected with a certain amount of blood glucose, the level of insulin are shown in this blue line. But once the same amount of blood glucose is given orally, the amount of insulin is clearly shown here in green line, and the difference you can well imagine, which is shown here, and the difference between the two is known as the incretin effect. So incretin effect is the difference in insulin secretion once a bolus of glucose is given IV as compared to orally, and this effect is responsible for the secretion of insulin when the patient takes diet orally, and this effect is seen impaired in patients of type 2 diabetes mellitus as shown in the second graph. You can see here that incretin effect is blunted or diminished in cases of type 2 diabetes mellitus. So There are three major components of the pathophysiology of the type 2 diabetes. That is, number one is insulin resistance, number two is beta cell dysfunction, and third one is incretin impairment. When we talk about the progression of the type 2 diabetes mellitus, insulin resistance is the first thing to come. And insulin resistance is primarily due to genetics of the person. The person is genetically predisposed to this condition, and there are certain other environmental factors which are responsible for increasing this situation. They are the obesity, sedentary lifestyle, and aging. Amongst these, aging is non-preventable, but we can prevent sedentary lifestyle and obesity. And once we prevent these two conditions, the insulin resistance and onset of diabetes can be delayed. Insulin resistance, in turn, the person when the insulin is not working properly, the target cells are not responding to a given amount of insulin, body tends to produce more insulin. So the first defect in type 2 diabetics, the persons who are prone to develop diabetes mellitus, is hyperinsulinemia. The levels of insulin in the body are higher as compared to the normal individuals to compensate for the insulin resistance. Once the condition persists, the compensated insulin resistance for a quite a longer time maintains the normal glucose tolerance. In these individuals, the only defect is hyperinsulinemia, but once we check for in glucose levels, there is normoglycemia in the body by the virtue of compensated hyperinsulinemia. Ultimately, when the body fails to compensate for insulin resistance for a given period of time, impaired glucose tolerance develops, and then comes the beta cell failure. Again, it is genetically predisposed patients. Beta cell fails to respond to insulin resistance for quite a long time, and ultimately, due to the beta cell failure, the type 2 diabetes occurs. In again, like insulin resistance, in beta cell failure, environmental factors, they also play a role. And in those acquired factors, glucotoxicity and increased levels of free fatty acids play a role. Other factors are the other factors include different endocrinopathies like Cushing syndrome, growth hormone excess in the body. All of these in combination, they produce beta cell failure and ultimately the development of type 2 diabetes. The type 2 diabetes is clearly evident due to insulin resistance, increased production of glucose from the liver, and definitely decreased insulin secretion. When we see it in another fashion, you can see in this graph that before the diagnosis of diabetes mellitus, insulin resistance is there 4 to 7 years before the diagnosis of diabetes mellitus. Insulin resistance increases gradually, and due to insulin resistance, definitely the insulin levels in the body, they starts increasing and they compensate for this insulin resistance, and that hyperinsulinemia persists in the body till the beta cells failure occurs and beta cell function deteriorates, and it fails to compensate for increased insulin resistance at a time given time, and insulin levels, they start decreasing. That is the point where hepatic glucose production started to rise, and postprandial and fasting plasma glucose, that started increasing, and at this level the frank diabetes develops. And you can also see that the microvascular complications are directly related to the increased levels of glucose in the body, but macrovascular complications are there even before the diabetes diagnosis, because they are not only dependent upon hyperglycemia. There are certain other factors in which definitely insulin resistance played a pivotal role, that is the hypertension, hyperlipidemias, dyslipidemias, hyperuricemia, and non-alcoholic fatty liver disease. They are all interlinked, and they are dependent upon insulin resistance, and that is why they are independent, they are not 100% dependent on levels of glucose in the body. So now we will talk about the clinical presentation of the disease. The classical presentation of hyperglycemia is polyuria, polydipsia, polyphagia, and weight loss. Usually these four are present in type 1 diabetes mellitus, but in type 2, as the onset of disease is insidious and hyperglycemia is very gradual in onset, these presentations or these symptoms are not present usually in type 2 diabetes mellitus. Type 2 disease is usually presented with complications of the disease like blurred vision, poor wound healing, increases in the infections like candidial, vaginitis, balanitis, urinary tract infections, and malignant otitis externa. So, the clinical features, definitely polyuria, polydipsia, polyphagia, weight loss are important, but they are pathognomic of type 1 disease. If a person presents with these typical symptoms, we should consider sudden loss of insulin in the body, and this is a feature of type 1 disease, as I have already mentioned. In type 2, the person usually presents with the complications, and those complications may be nephropathy, neuropathy, or poor wound healing due to persistent hyperglycemia in the body. Talk about complications very briefly. We will go through the complications which are macrovascular in origin, and the others we classify it as macrovascular disease or microvascular disease. Amongst microvascular complications, these are 100% or most of the time they are related to hyperglycemia alone. That is diabetic eye disease, retinopathy and cataracts, renal disease, nephropathy, erectile dysfunction, and peripheral neuropathy. These are the microvascular complications, and these are seen when the patient is not controlled properly on, and once the person is controlled, the incidence of these complications can clearly be reduced. The other complications of diabetes, they are called the macrovascular disease. Amongst those, the stroke, heart disease, peripheral vascular disease, and foot problems are included. These are the problems which are not 100% dependent upon hyperglycemia alone, and they are also associated with other problems like hypertension, dyslipidemias. And once the diabetes is controlled and these factors are not properly controlled, even with proper control of diabetes, the incidence of these complications are reduced to a minimal extent as compared to the microvascular disease. So it is very important to remember that once we need to control the diabetes, we should also be focusing these other factors which are associated in macrovascular disease. Now we come to the diagnosis of the diabetes mellitus. The diagnosis of diabetes is made when the patient presents with classical symptoms, that is polyuria, polydipsia, unexplained weight loss, and on upon checking of his blood glucose, casually the levels are beyond 200 milligram per deciliter, as we discussed when we were learning about the definition of diabetes. Casual means any time of the day, irrespective of the time since last meal. And fasting means no caloric intake for at least 8 hours. So, postprandial if it is more than 200 milligram per deciliter, and fasting if it is more than 126 milligram per deciliter. In the with the presence of typical symptoms, the diagnosis is very clear, and the patient is diagnosed as a case of diabetes mellitus. Or if the person is subjected to oral hypoglycemic, oral glucose tolerance test, and his 2 hours postprandial glucose is more than 200 milligram per deciliter with typical symptoms. The patient is diagnosed with diabetes. Categories for fasting plasma glucose. When we test fasting plasma glucose, the levels of fasting, if they are less than 110, or nowadays it is said that these levels should be reduced to 100, the person is called normal. If fasting is more than 125 or more 126 milligram per deciliter, the diagnosis of diabetes is made. But in between the two, previously it was known as impaired fasting glucose, but nowadays it is called as pre-diabetes. The categories with oral glucose tolerance test is 2 hours postprandial glucose. If it is less than 140 milligram per deciliter, it is normal glucose tolerance, or the person is declared normal. And if 2 hours postprandial glucose is more than 200, provisional diagnosis of the diabetes is confirmed. And in between the two, previously it was known as impaired glucose tolerance, but nowadays it is very clearly said as that it is pre-diabetes. Intermediate group of subjects with glucose levels not meeting the criteria for the diabetes but higher than normal, that is fasting plasma glucose of more than 100 and less than 126, it is called as pre-diabetes. And 2 hours postprandial levels more than 140 and less than 200, they are called as pre-diabetes or impaired glucose tolerance. So the things to remember here is, if the levels in fasting are less than 100 milligram per deciliter and less than 140 milligram per deciliter in postprandial state, the person is non-diabetic or normal. And if the levels are more than 200 milligram per deciliter in postprandial state and more than 125 milligram per deciliter in fasting state, the person is diabetic. In between these two is pre-diabetes. What is oral glucose tolerance test? Oral glucose tolerance test is done when casual plasma glucose is in pre-diabetes ranges. And how the patient is prepared: 3 days of normal diet, carbohydrates more than 150 gram per day. Overnight fasting is necessary, that is 10 to 16 hours with water as wished. The person should be seated or semi-recumbent comfortably and quietly for 30 minutes prior to and during the test, and there should be no smoking or no exercise during the test. Test best performed in the morning and not taking drugs that interfere with glucose metabolism. In adults, 75 grams of anhydrous glucose is given, and in child, 1.75 gram per kg body weight to a maximum of 75 grams per person, dissolved in 250 to 300 milliliter of water, and it should be taken over 5 minutes. Samples, there should be only 2 samples, that is venous or capillary blood for either whole blood or plasma glucose estimation. The WHO protocol says that only 2 samples are required, that is initially 0, that is in fasting state, and 120 minutes after the ingestion of that glucose solution. Urinary samples are not necessary except to determine renal threshold for self-monitoring control, but nowadays self-monitoring is not recommended with urine samples because different threshold levels, and only plasma glucose levels are acceptable for self-monitoring as well. Once the person is diagnosed as a diabetic, there are certain other tests which needs to be performed, that is HbA1c, fasting lipid profile, to look for lipid abnormalities. As I have already mentioned, that macrovascular disease is dependent upon the lipid levels as well. Then to look for complications like nephropathy, serum urea and creatinine should also be looked for. Urinalysis should be ordered to look for microalbuminuria or total proteins 24 hours in 24 hours. Urine culture to rule out any urinary tract infection if there are symptoms of that. TSH levels to look for the association of other autoimmune diseases and rule out thyrotoxicosis or hypothyroidism in type 1 diabetics. ECG should be performed in all the persons who are beyond 40 and urine ketone testing is important, as type 1 patients and pregnant patients with gestational diabetes mellitus or pre-existing diabetes with suspicion of diabetic ketoacidosis. It should be performed in all patients of type 1 who are suspected type 1, and if ketoacidosis is present, then there are more chances the patient is having type 1 disease. When we are to assess the glycemic control, there is a very popular test known as HbA1c glycated hemoglobin. It reflects the previous 2 to 3 months of glycemic control. HbA1c values predicts the risk for development of diabetic complications and is a standard for evaluating the control. And HbA1c testing recommended for all patients with diabetes mellitus. The goal of therapy is HbA1c less than 7% and re-evaluate treatment with HbA1c consistently if it is more than 8. The other test which can tell us about the previous control is glycated serum protein levels. They provides an index of glycemia over a shorter period of time than does HbA1c, the preceding 1 to 2 weeks as opposed to 2 to 3 months in HbA1c. Estimation of HbA1c is very important, mind it, and it is also nowadays used in the diagnosis of the disease. The levels below 5.5 are considered normal, and if the person is having levels more than 6.5, it is diagnosis of it helps in diagnosis of diabetes mellitus. So levels below 5.5 normoglycemic, patient is normal. Beyond 6.5, patient is diabetic, and in between the two, again the patient is pre-diabetic. So at the end of the today's lecture, I will summarize it for you. The pathophysiology of the disease in type 1, mind it, the main pathophysiological event is autoimmune disease, and it is the destruction of beta cells due to autoantibodies. In type 2, it is multifactorial. The underlying problem is insulin resistance, beta cell dysfunction, and incretin impairment. These are the major three pathophysiological defects which are found in patients with type 2 diabetes mellitus. The diagnosis of type 2 is made when the patient is having classical symptoms plus one reading beyond 200 milligram in postprandial state and beyond 125 milligram per deciliter in fasting state. In between, and if the person is having 140 milligram and less in patients of postprandial state and less than 100 milligram in fasting state, the diagnosis of diabetes is ruled out. In between these values, that is called the pre-diabetes. Another factor which is important in the diagnosis of diabetes, another test, that is HbA1c. The levels below 5.5, they are normal. Above 6.5, the patient is diabetic, and in between the two, the patient is pre-diabetic. So please give it a reading in your at your home so that we can continue with the management of diabetes in the next lecture. Thank you very much.